Friends, a very good morning to all of you out there, and a very, very warm welcome from the entire team of Rfa Tutors. Your mentor this side. I hope everybody is doing great. 40 years patient. She has history of 2 cesarean sections, so I expect adhesions. She's complaining of abdominal pain, which is not responding to opioids. Pain can be positive in all injuries. Okay, so she is not responding to antipyretics for this as well. Urine output was satisfactory overnight, but after removal of the catheters 8 hours ago, she has not passed urine. This is not bowel. Understood? This is not bowel. Claire, after 8 hours when the catheter's been removed, she has not passed urine. Got it, everybody? Did you guys understand? Tender and moderately distended abdomen. If it is bowel, here I will have guarding, not tenderness only. Guarding, rigidity. Did you guys understand? I will have guarding, I will have rigidity here. For this situation, I do not trust that it is bowel. Bowel sounds are absent. I agree that this should go towards the bowel, but it is understandable that when the fluid is there, we might not be able to listen to the bowel sounds. Okay, therefore, in this situation, we are concerned about that how basically the urine is less. Abdominal scan is showing moderate free fluid with minimal urine in the bladder. Do you still think it's bowel? Do you still think it's bowel? No, for this, I don't want to go to the bowel, please. Hemoglobin is 10. Now, let's see the options. I will figure out everything. Bowel perforation will have guarding, rigidity, plus I will have something related to vomiting. So this is my note. Only thing which is confusing me is, listen to me very carefully, the bowel sound is absent. That doesn't mean that I go to bowel perforation, right? My patient's HB is 10, which is quite a good one, I don't feel. Similarly, they've not given me hypotension or tachycardia. Do you guys agree? If this is not there, my abdominal bleeding is never there. Okay. Paralytic ileus would be severe distension. They wrote it is a mild distension. This would be severe distension plus hypokalemia. I don't have this. I agree that bowel sounds absent goes with this, but I have to see the whole scenario, guys. Right? Now I have bladder injury, now I have urine. This is for sure that this is something related to the urinary tract. Bladder injury would not be late presentation, right? Bladder injury would be quick presenting generally. If a patient has been having catheter, have been having the issue earlier, and moreover their fibroids, these are adhesions for these surgeries. If it is bladder injury, I would also think about hematuria, right? I would think about early presentation. So as compared to all these options, ureteric injury seems better option. If it is hematuria after hysterectomy, always bladder. Minimal urine in the bladder plus free fluid, Ibrahim, please understand, it is going to be ureteric injury. Ala, you're there? If it's a delayed abdominal pain, think about thermal bowel injury. Free air under the diaphragm. Think about bowel perforation. If it is a discharge in the wound in the vagina, bowel. Shock plus rapidly falling HP. It has to be vessel injury. Tachycardia. Think about the bleeding. If I give you a scenario with no menarche since the beginning, of course, primary amenorrhea, I'll think about my Müllerian agenesis first. If I think about absent secondary sexual characteristics from the menarche, of course, I will think about the hypogonadotrophic first because she doesn't have the breast development. I don't have the FSHLH there. If I think about short stature web nuck, I think about the Turners first. If I have cyclical pain in my exam question, I think about the outflow obstruction first. A 44 years old asymptomatic patient, HPV is positive, severe dyskaryosis, transformation zone is not seen and feature is consistent with SIN 2 and 3. What would be the next step in that case? Now, HPV is positive and severe dyskaryosis is there, and I'm not sure about the transformation zone. I have to make sure my diagnosis. I have to rule out the cancers. Let's take other options one by one. Transformation zone is not seen and features are consistent with SIN 2 and SIN 3. One option is that I directly do, let's discuss this, guy. I directly do LETs, and what if it comes out to be a cancer? Do you guys get it? What if it comes out to be a cancer? So I'll be wrong, right? I do cervical biopsy and immediately I do coagulation. Coagulation is not a preferred treatment. LETs is preferred. So, no. There's one girl. Anam, she's 44. Let's remove the uterus. Yes? Yes? Anam. No, I love you. So hysterectomy should not be done immediately, guys. Okay? Right. Repeat smear. Right? Repeat smear. I would not do. Why? Because I already have dyskaryosis. Remember, functional ovarian cyst. With this situation, the follicular cyst before the ovulation, the first half of the cycle. The corpus luteum, the hemorrhagic cyst, is after ovulation. Please understand this because they will give you the timing. In exam, it would be, this is the ovulation date, for example, day 14. If she is in the first 14 days, it would be what? It would be follicular cyst. Am I clear? Did you guys understand? If they give you a cyst after the ovulation date, then it would be hemorrhagic cyst. I hope I'm making it clear. Did you guys understand that? Right? So timings are very important for a 13 years old having a cyst. These are all exam questions till March 2026. Now, this is for the mean gestational sac, right? Diameter. But then we have the CRLs. CRL 7 mm is the cutoff. No heartbeat is there, diagnosed miscarriage. But less than 7 mm and no heartbeat is there, please repeat scan in 7 days. Got it, everybody? Then we have to repeat scan in 7 days in that situation. You have to understand that if it's an empty sac and positive pregnancy, confirm with repeat scan. No yolk sac, fetal pole at early gestation. Repeat the TPS. Thank you very much. Remember in prayers, I'm going to see you guys with the next session. Until we meet again, take very good care of yourself and remember in prayers. If any questions, any feedback, anything is there, stay connected. You've got my Instagram, you've got my WhatsApp. Drop in a message. Please remember, we are not here to just pass this exam. We have to score higher and higher. All my prayers are with you guys. With all this togetherness and blessings, let's meet once again. Bye-bye, everybody. Best of luck from the entire team of Rfa Tutors. See you guys. Thank you very much. Bye-bye.